The broadcast is now starting. All attendees are in listen-only mode.
Hello everyone, welcome to today's webinar. Today we are joined by two representatives from the Oregon Foundation for Reproductive Health, Hannah and Michelle, to discuss one key question. Michelle is the Executive Director of the Foundation and brings decades of experience in women's health and healthcare policy. She is the creator of OKQ and continues to work to increase opportunities for women to receive appropriate health services based on their needs. Hannah is a Senior Policy and Access Coordinator with the office, and she primarily works on the One Key Question initiative and provides support for sites that plan to implement OKQ. She also represents OFRH statewide on issues of access and affordability within reproductive health care. Before we hear from these two, please note that all lines are on mute. This presentation includes a couple of live audience polls which will remain displayed for about a half minute. Use the questions box for all other comments and questions. Q&A will open immediately following the presentation. Now, without further ado, Hannah, you may begin when ready.
All right. Thank you so much, Teddy, for including us in the webinar today. We are excited to share one key question with all of you. So Michelle and I will give our presentation on this initiative and then take your questions at the end. And we'll also share our contact information. So if you want more information or if you want to bring one key question to your site or campus, you can connect with us and let us know. So also, just so everyone knows, I am in control of the webinar, and so Michelle might be asking me to move slides back or forth, and that's why.
Hannah is in control. Hello, everyone. This is Michelle. Thank you so much for joining us today. I'm really excited about this opportunity to talk with you all about one key question, which is a strategy. It's a tool. It's a tool to dramatically increase women's access to preventive reproductive health services. And I'd like to take a few minutes to give you some context from where this came from and why it has become really as popular as it has. As Teddy said in my introduction, I have been at this for decades. I admit it. I came from a family planning background and then went into women's health in more general ways, and then did work in administration around women's health. I came back to what I consider the front lines of reproductive health services, really partly in frustration, seeing that women were still having unintended pregnancies at the rate of about half of all pregnancies being unintended, not the timing that they wanted, some of them unwanted pregnancies, but primarily mistimed pregnancies, and seeing the impact that that has on women's lives and their children's lives and their families' lives. And it just seemed to me that there must be something going on, that there's been such an increase in healthcare service delivery. There certainly was an increase in family planning clinics availability across the country, and yet we still have this significant unmet need in terms of women accessing information and services to make that very personal decision about if or when to have children. So I traveled the state of Oregon talking with primary care clinicians and community stakeholders to try to get a sense of what was going on. And what I heard, much to my surprise, but I heard it repeatedly, from clinicians was, well, I don't talk to women about birth control. I don't. She goes somewhere else for that. Now I'm talking about primary care. She goes somewhere else for that. Well, where does she go? Well, she goes to an OBGYN or family planning clinic. And what I discovered from that 18-month adventure was that Oregon was by no means unique. that this, across the country, we have siloed our healthcare delivery service for women's health between primary care and women's health specialists. And as many of you know, that just is not the reality of women's lives. I mean, we have one body, we have one healthcare, and our healthcare status has a huge impact on the health of a pregnancy when we conceive. So that this separation in the service delivery system did not just impact pregnancies that were unintended, but it absolutely had a huge impact on birth outcomes. And it was clear that there really wasn't anyone, no one specialty, no one profession, no one service that was really doing both, that was really approaching women from both the being healthy before you conceive side, as well as from the let's prevent an unintended pregnancy if you don't want to become pregnant, that we too were siloed. So one key question was really born from that recognition that women's healthcare is fragmented and not coordinated, and it approaches women as pregnant or non-pregnant. And we need to change that approach. One key question in primary care. Now, I actually have to admit, the original question that I went out with to women in focus groups and surveys was, do you plan on becoming pregnant? And that was the wrong question. When we asked, do you plan on becoming pregnant or do you intend to become pregnant? It's the wrong question. That what no one had ever asked women before was what they want. What do you want? What would you like? Do you want to become pregnant in the next year? Would you like to become pregnant in the next year? So the emphasis here is on this question being integrated into primary care. Now, into primary care, because that means she's going to have the best possible access, that it isn't relegated to women's health specialists. But frankly, what we've discovered over the last 5 years as we have been seeing One Key Question implemented, this is a really useful, critical question at family planning clinics as well. And it is really it's a useful question in community services, Head Start, WIC, public health programs that are routinely seeing women, to be asking them about their pregnancy intention so that we can start a conversation about preventive reproductive health care. We want to give women the opportunity to get the information and services she needs so that pregnancies that are unwanted or mistimed can be prevented. And equally and critically important is to increase the proportion of pregnancies that are better prepared for so that they can be as healthy as possible. As an organization, we are committed to providing support to providers and community services to help them implement this. That one of the ways that we see doing this is through custom consultation. We're doing this webinar. We're giving you the general sense of what One Key Question is and how it works. But I want you all to know that we also have very specific, a specific toolkit, an implementation manual, and we work with providers to talk very specifically about their setting, what their resources are, what their capacity is, and help them design the very best way to be inclusive of this approach in talking with women. And we'll, of course, give you our contact information at the end. Now, again, the context for this is the reality that the average woman is indeed fertile for about 39 years. And we know on average she has 2 children, and on average she spends 5 years pre-pregnant, pregnant, or postpartum. And by anybody's math, that means she's spending over 30 years trying to avoid an unintended pregnancy. And as we talk about chronic conditions in our healthcare transformation world, we are suggesting that reproductive health and the prevention of unintended pregnancy needs to be treated and recognized as any other chronic condition. We need to give women the support and the services she needs. About half of all pregnancies right now are unintended. And when you think about that, you know, that by age 45, more than half of all American women will have experienced an unintended pregnancy. The impact of that, when you think about it, it begins to be worth reconsidering how you do what you do to be more proactive and more routine about asking women what she would like, what she wants relative to becoming pregnant, and then offering her services either directly or by referral that are based on what the woman's response is. We know that most unintended pregnancies are either unwanted or mistimed. We know they could be prevented with better access to contraception. And we do still know that unintended pregnancies that are wanted could be better prepared for with access to preconception care. I think for any of you that have been dealing in preconception care, you know the research is pretty clear in terms of the health problems for both the woman and the infant that are associated with unintended pregnancies. There is a much greater incidence of preterm birth and low birth weight and increased infant mortality. And in fact, the COIN project, which is also a national initiative designed to reduce infant mortality, has adopted one key question as a critical strategy for reducing infant mortality, because it will routinely and proactively introduce preconception care into whether it's healthcare conversations or social service conversations, and then getting the woman to the services that she needs. We know that with unintended pregnancies, there is delayed prenatal care. And we know that once, of course, that's the other part of the research, is how critical it is for the woman to get prenatal care within the first trimester. But what I'm really stressing here is the work that you all are doing related to preconception care is that's when it needs to start. You know that by the time she gets into prenatal care, many of the conditions that affect fetal development have already been in place, either because of the health status that she brought to that moment of conception or the health risk behaviors that she took when she had no idea she was pregnant. Because, if it's an unintended pregnancy, it's very common to not know that and not be thinking in terms of, well, I really shouldn't smoke or drink because I might be pregnant. We also know unintended pregnancy leads to depression and anxiety, and there's a much higher likelihood of physical abuse during that pregnancy for the mother. Thank you, Hannah.
All right, so this will be a poll that you can connect your answer with. So the poll is: the Affordable Care Act requires coverage of which services at no cost to the consumer? And this is just for us to get a chance to test what your knowledge is right now. All right, and just a few more seconds on this, and then we'll close that poll and move on. Share the answers.
Well, excellent. The majority of you knew that all of the above, all of these things are covered by the Affordable Care Act. That is the greatest news, and of course, in my opinion, that's the greatest news about the Affordable Care Act. It's the best thing that's happened in women's health in my lifetime. That we do have these services now available to women at no cost. And it includes folic acid. So that I know that even though it's been an inexpensive drug or supplement, it doesn't matter. That our ability to be able to freely distribute it or for a woman to get it without any cost removes a barrier.
And the interesting thing is that a lot of the sites that we go out to visit to talk about this, we're still providing education about different parts of the Affordable Care Act that do include these pieces. And with the event of this coverage really helps One Key Question move along as the evidence-based care that we recommend for women who are either interested in becoming pregnant or not is now a covered service. So we're removing that barrier. Let's see.
Yes.
Sorry, my screen is froze on this, so technical difficulty.
Well, I can keep talking.
Yeah.
So everyone just pretend that the screen has changed now, and it says our solution. Our solution is, I'm repeating myself, ask all women of reproductive age at risk of a pregnancy one key question in a routine and proactive way, regardless of the reason you're seeing her, regardless of the reason for the visit. Ask women, would you like to become pregnant in the next year? Okay, now the next slide. Pregnancy intention screening. That's the language we have available to label this one key question. It's a screening tool to help identify the women in need of preventive reproductive health care and to know what services she actually needs, and not assume we know what those are. The question itself is, would you like to better address what the patient's goals are for her health? It's very patient-centric. It's neutral. It equally supports women who want to become pregnant and those who do not. So you're going through a very neutral door. And when you go through that door, you're then directly connecting with evidence-based care, whether that's preconception care or contraceptive care, that will have a big impact on your patient population's health. We recognize that there are barriers, system barriers. To the next slide. That there are systems barriers, but there are also risky assumptions that providers make. That we may look at a woman's situation and say, well, she shouldn't become pregnant. I'm not going to talk about preconception care. Or the assumption, as I was saying earlier, that the patient is getting reproductive health care somewhere else. Or that a patient actually knows exactly how to use birth control. That is a huge assumption that just is not being proved out, frankly, in reality by the research, that there is a lot of misinformation or misunderstanding out there. And then the next slide is more the systems barrier, that it's too time intensive to ask. I mean, I heard initially over and over again, and I do still hear it now on occasion, where, providers will say, I only have 15 minutes per patient. I can't possibly do this. You can't ask me to do one more thing. And we do understand that. And that's in part why we have gone out of our way to really look at the different issues with clinic flow and workflow and the team of providers who can be involved in doing this so that it is the least, let's say, puts the least stress on a clinic service or your service delivery system. We have had many pilots at this point, and we know that it is feasible in a primary care visit, and it's very acceptable to patients to ask, even at a non-reproductive health care visit. Women tend to say, wow, no one's ever asked me this question before. Thank you. I didn't know I could talk about this here. We also know that only about 30% of the women actually need the follow-up care. Now, why is this so critical to happen in primary care? Because it's so essential to manage those chronic conditions before conception. And I would add, the other part of that is the medications that women are on that are toxic to a developing fetus, so that as primary care is doing its quality care, if you don't recognize what her reproductive health intentions are, you may actually not be providing the very best quality care. So you can change, her pregnancy intention can change. I refer to it as a moving target. I mean, honestly, how I feel today may be very different than how I feel next month or a couple of months from now. And it is definitely a question that needs to be asked as routinely as you have the capacity for, and not just on a once-a-year basis or in a well-woman visit. And as we just went through with our poll, the Affordable Care Act does require all insurance, public and private, to cover preventive care for women, all birth control, some preconception care, certainly the kind of preconception care we're talking about, and folic acid, and prenatal care. So the next slide, so poor primary care, right? Primary care is being asked to do all of these things routinely. Depression screening, alcohol, cervical cancer, breast cancer, blood pressure, diabetes screening. And what we just want to point out to you in terms of the lifetime risk to these conditions are actually relatively low compared to unintended pregnancy. And this is their condition in a lifetime. If I gave you the data that's just for women of reproductive age, of course these numbers would be dramatically lower, except for unintended pregnancy. And then think about how dramatically unintended pregnancy can impact the life of the woman and her child and her family, that it's worth a screening. And it's also worth a screening in a variety of different settings. WIC, home visiting services, early Head Start, dentists. We have dentists who are saying, I have to ask before I do an x-ray, gee, can't I do something a little bit more with that information? So we're going to go through what the screening and the follow-up care looks like in a healthcare setting.
And so you'll see on the screen our simple algorithms that we share with healthcare centers to kind of give a visual for what we have. So not only is our question unique, would you like to become pregnant in the next year, but we also have 4 unique answers. It's not just a yes or no question anymore. We want to make sure that there's space for a woman or person who can become pregnant to answer okay either way or unsure. After spending some time in the family planning clinic myself, I did see and hear from so many people who really were either unsure or they were in the category of it happens, and our clinical system really isn't set up yet to be able to accept those answers. So when sites do take on one key question, we ask them to start tracking information on women who say okay either way or who are unsure. And when they answer that, there's a little bit of a change in the information that you give, but it actually doesn't have to steer your visit in a completely different direction. It's just rather a combination of preconception and contraception care based on where she is. So we'll go through this further. If your patient does answer yes, she would like to become pregnant in the next year, we recommend basic preconception care. So this includes screening for conditions that can affect pregnancy, and some of these are high blood pressure, at risk for diabetes, obesity. We also recommend reviewing the medications that she's currently on or medications that might be prescribed that day, knowing that your patient might want to become pregnant soon. We also do recommend folic acid. It's actually pretty common knowledge for folic acid to be given at a prenatal visit, but we actually are saying, and it is best practice, to take folic acid before you become pregnant. And so you can give a prescription for someone earlier on. And also talk about the benefits of birth spacing, which in our community we heard was a big message that needed to get out there. We also have a full preconception care checklist that's available for healthcare centers. We go through what they seem to be doing pretty routine and regular, and then we also see if they have any goals for their certain patient population, or if there are things on here that they aren't necessarily doing at all and they want to make sure that they're targeting. So information about advice to reduce and eliminate alcohol, tobacco, and street drugs, screening for STIs, diabetes, and hypertension, checking if immunizations are up to date. Of course, recommending a healthy diet, exercise, sleep, stress reduction. We do have advised dental cleaning and checkup, screen for risk of intimate partner violence, and of course, establishing a relationship with a primary care provider if this is not being done at a primary care provider. And we are in connection with the Before, Between, and Beyond Pregnancy, which is a national preconception care work group. On their website, they do have current recommendations for preconception health strategies, CME credits for those who need that, but also a lot of good current recommendations. So health centers who need a lot more information on preconception care, we use the Before, Between, and Beyond toolkit to help them kind of assess that preconception care. And then there is, of course, the Show Your Love, Steps to Healthy Me, and then they also have Healthy Me and Baby to Be, which is a great tool for patients to take home. It's a checklist that includes preconception care advice. So if your patient answers no, we do want to talk about contraception care, and we want to do comprehensive contraception care. So it's not just, it is asking if they're currently using a birth control method, but it doesn't stop there. You also need to check with the satisfaction of her current method. A lot of women are using a method that they've just been on because of either cost or access issues. We know that there's a lot more birth controls out there, and cost has been removed as a barrier, so we need to discuss more options. And those include the long-acting reversible contraceptions, or LARCs, like IUD and implant. And we also really recommend including information and prescription for emergency contraception with a birth control, either first time or refill. This is great because the patient can have a prescription on hand and can pick it up as needed instead of having to wait till it is either an emergency after hours or on the weekends when she might need emergency contraception. We're going into another poll just to check your knowledge of contraception. So this is, which of the following statements are true? More than 99% of women have used at least one contraception method. The most common birth control used is the pill. The most effective birth control is the implant. Emergency contraception can be purchased over the counter, and is also covered by insurance with a prescription, or all of the above. And I believe Teddy has opened up that poll so that you can vote, and it will stay open for the next 30 seconds. We've got 5 more seconds. Okay. Okay, and it's closed, but actually I couldn't see the results last time. Michelle, can you see them?
I sure can.
Okay.
So we have more than 99% of women have tried a contraceptive method, 10%. The most common birth control is the pill, 11%. The most effective birth control is the implant at 3%. And emergency contraception is available over the counter and under insurance at 11%. And once again, the majority got the absolute correct answer, all of the above, at 54%.
Great, that's wonderful. In choosing the polls, I basically wanted to use them as a way to get all this information out. So it is true, all of the above are correct. And when we're thinking about comprehensive contraceptive counseling, these are some of the critical pieces to keep in mind. And like we said, with contraception, many women are using a short-term or less reliable method because it's just what they're used to. But the best method for women can change over time with a pregnancy, with a new partner, a new job. So it is important to check in to see if a new option might be better for them. And now we do have, again, the great long-acting reversible contraceptions that can be ideal for many women. We use this, it's the Bedsider tiered contraceptive counseling sheet for patient education. And you can see we do recommend contraceptive counseling starting with the really, really well methods. So we want to talk about tier 1 that are the most effective. These are all over 99% effective. So if a patient is telling you that their goal for their own health is to not become pregnant within the next year, you want to make sure you're offering them the birth control method that is going to best help them meet that need. These might not be the right choice for most women, or for some women, excuse me. Then we have the tier 2 that are pretty good. The pill, the patch, the ring, and depot. These are more common. You can also see for it to work, it's best to use. We have different ways that you can use it, different lengths of time, and then the not so well methods that we probably wouldn't count on to really meet that goal of not becoming pregnant in the next year. So we talk with primary care providers about counseling, and it does include more than just how to take it, but women really want to know how effective it is, how to start the method, how to use the method consistently and correctly, and what they can do if they make a mistake. What are the advantages? And they also do want to know about the risks. So these are all things to take into consideration when you're starting a patient on a new birth control method. And we do offer some really good patient education and clinic education materials that go through all these steps for all the different methods. So the sites that start using one key question, we make sure that they have this accurate, up-to-date information on contraception counseling so that they can make sure their patients are using the birth control most effectively. You can see, again, we have this tiered method patient education material for emergency contraception as well. The Paragard or copper IUD is actually great at emergency contraception. So which is not actually well known, but if a woman is coming in and would like a Paragard, that could be a really good tool. We also have Ella, which is our prescription emergency contraception method now, and it is good for up to 5 days after any unprotected sex. And then we have Plan B and the generics, which is now over the counter, but can also be covered as a prescription. And it's best to take it as soon as possible, with the most effective up to 3 days. And you can also note on here, and it talks about, I guess it's a little fuzzy, but the different BMI levels. So as a provider, it's going to be important to know which one is going to be effective for your patient. So we do talk about LARCs a lot because they are pretty new to a lot of providers. They're just kind of becoming, more people are becoming comfortable and getting them. So we talk about LARCs. And again, those are the IUD and implants, protecting against pregnancy for multiple years. And they're so effective because they do reduce the user error. So there's nothing a woman needs to do to make them work once they're placed by a provider. They're more effective than other methods with fewer hormonal side effects. And also, women can have them removed at any time with a rapid return to fertility. We have information here about the different IUD methods, and there's actually an additional IUD that just came out. So more and more technology is allowing these to be more readily available for women at all income levels. And then both the implants are good for 3 years, and that's inserted into your arm. Boop, boop. And then, like I said, we do have the unsure or okay, either way option for patients to answer. And this does involve offering a combination of contraception or preconception care, kind of based on where she is or what kind of issues are important to her at that time. Some women are unsure or ambivalent if they have never been asked. So you can start the conversation with a couple more questions about timing, resources, about maybe having another child could impact the family or plans, work plans. And then we also recommend using a 1 to 10 scale to gauge really the ambivalence about how important it is to prevent pregnancy. So if someone was at the higher end of a 10 scale or a 1, you would know, you could gauge if they were more interested in hearing about contraception or preconception care. And it's just a good way to start the conversation. Here are some follow-up responses about either recommending you choose a contraceptive method until you're ready. We also know that just letting women know 85 out of 100 women who have unprotected sex will become pregnant within a year's time. It helps to give some context into how often that does happen. And then just some pretty basic questions about how would you like help today and how you can help them reach their own goal for their health. And then I would share just at some outcomes. One key question has now been rolled out at multiple sites, but a community health clinic here in Oregon, we found that about 30% of women did need follow-up care with contraception or preconception care, while 70% did not require any follow-up services. So really those having the conversations with women is not going to have to happen at every visit. And then again, in the public health clinic, about 60% of women were happy with their current method, but 23% did receive a new birth control, and 12% were given some preconception care and advised to start folic acid, which would not have happened if they weren't screened with one key question.
So again, one key question is designed really to start a conversation about preventive reproductive health care and primary care, a conversation that you may be having already. It organizes that conversation and it makes sure that it just happens routinely. And it is designed to prevent pregnancies that are unwanted or mistimed and increase the proportion of pregnancies that are better prepared for. Would you like to become pregnant in the next year? We want to stress our availability. Myself, Hannah, will readily work with you around how to implement this. We also have a wonderful medical director, Sharon Myron, who works with us and will work with clinicians in helping them also. So I think that stressing our availability, please ask us questions. What would you like us, what haven't we addressed? What else might you like to know?
Okay, with that, we are opening up our Q&A session. Thank you, Hannah and Michelle. Our first question is, do religious organizations have the ability to opt out of insurance coverage for contraceptive care and family planning when it comes to their employees?
Would you ask that again, please? Do they have
Sure.
the option of opting out? Go ahead.
Of insurance coverage that allows for contraceptive care and family planning for their employees?
Well, that's an interesting question. That is a decision that has been made, yes, by the Obama administration, that religious organizations do have a way to opt out. Yes.
All right, thank you for that question. The next question is, has OKQ been identified as an evidence-based or evidence-informed tool?
It's an evidence-informed tool, but the stress here is it's a tool, right? That the evidence-based care is what it connects you to. It's effective as a way to get there. Recently, August, there was research just released that was done through Dr. Susan Wood and the Milken School of Public Health out of George Washington University, where they tested one key question as the question that was asked among patients at federally qualified health centers, for example. And by asking the question, they identified that 30% of the women who didn't want to become pregnant were not using any contraception. And other tools will only show up. The average that comes up is usually 10%. So that particular research went a long way toward reflecting how effective a question it is to ask and to get then to the preventive reproductive health care.
Okay, thanks. So next question is in regards to OKQ, and why not also screen for HIV and STIs as it relates to primary care and preconception care, and also when the patient indicates no?
So these are really kind of based on what what primary care isn't already mandated to do. And at least here in Oregon, we do have pretty rigorous routine HIV screening at least yearly. Of course, we would want to include much more in what we're saying should be done, but these are the points that we're really focusing on with the contraception and preconception care.
And in our toolkit, for example, when we're asked for more specific information, the list on preconception care definitely includes that.
Okay. When it comes to contraceptive care, how do you address women who do not want to put things inside their body?
Yeah, that's sometimes that can be one of the things that comes up when you're introducing the idea of an IUD and implant, and that's why we say it's not for everyone. So really kind of listening to your patient, understanding what really her concerns are. There are so many myths and misinformation and rumors about the IUD and implant that happened from long ago when they first came out, but these are new technologies. So really kind of I think starting a conversation, understanding where that fear or uncomfort level lies, and then it might not be the right method. So also really kind of understanding if the pill, patch, ring, or depot, or condoms might be something that she would use.
The next question is, is the Paragard really a realistic emergency contraceptive method?
Well, I think that is the key. The key term is realistic. So as far as effective, yes, it is the most effective emergency contraception there is, and you'll see a lot of new evidence that is the recommended approach. But realistic is a woman going to be able to make it to a clinic where she does receive a Paragard IUD same day, spot on, and that is the method that she wants to. I'm not sure. I think we're just going to see where it goes actually within the next couple of years with that.
Yeah, and I would just add that given the problems, or I should say the problems relative to Plan B, for example, is emergency contraception, and it being identified that weight, a woman's weight, directly affects how effective it is or isn't, and now you're talking about Ella as a prescription base, that a lot more providers are looking at the IUD as a real immediate possibility. But the realistic part comes in just in terms of which providers are available to do that, to give her that. That's going to be the question. Now, it is something else that is reimbursed, are assured to be reimbursed, based on the Affordable Care Act. So providers I'm seeing a lot more providers that are actually working to be able to do a same-day insertion because of that effectiveness.
Okay. So I have a couple of questions I'm going to combine. The first is, should a woman be taking folic acid as soon as she's of reproductive age? And if so, what is the recommended amount she should take daily? And the second part is, at what age are providers supposed to start asking the one key question?
I'm going to take the latter one, and I'll leave the folic acid for Hannah. This initiative, excuse me, is specifically designed for 18 to 50-year-old women. This is not because we think that it might not work with teenagers, but we did not assess it. It has not been tested with teenagers. We have a number of providers who are doing using one key question with adolescents. Certainly, if there's any reason to believe that adolescent is sexually active, it is happening that way. We did not choose to deal with it in any younger than 18 because our objective is really to affect the vast majority of reproductive age women and to show how by doing this we can really reduce unintended pregnancies and improve the health of those pregnancies that women want to have. So we did not go into the younger age group ourselves. That's an individual provider's choice.
And then as far as folic acid, one of the things about folic acid is that a lot of women aren't already getting enough that they need in their diet, and I wouldn't go as far as to say everyone who hits reproductive age should take it, but this is more on the path of someone who's indicated to you. Excuse me.
Yeah, if there's reason to believe, I'm trying to jump in while she's incapacitated here. Right, if you have any reason to believe. I mean, I certainly have seen some of the professional clinical recommendations being reproductive age, right, to take an amount of folic acid. just because it's a healthier course, regardless of whether she is intending to become pregnant or not. It does no harm. It's one of those things that does no harm.
Okay. You have another question. So the premise is there are some dentists who don't think there's a connection between birth outcomes and poor dental care. So how can we encourage more dental providers to use the OKQ? What's in it for them?
What's in it for them? Quality patient care. What can I say? I mean, the group that is doing dental care here in Oregon is a nationally based dental group, and they're collecting data, in terms of how effective it is, how their patients respond when they're asked the question. And I think based on that, this national dental group is very interested in seeing it go national. And from our experience with One Key Question in general, is that once one does, others absolutely consider it. I mean, in terms of incentivizing it in some way, I mean, honestly, I would like to see preconception care incentivize more among all groups of providers. So, whether that could happen specifically for dentists or not, I think that's a great idea.
Okay. What would you say to a patient who answers no, she doesn't want to get pregnant, but refuses to use anything but a male condom? And what would you say to those who are married and state that they don't want children? What's the best for those who are married and state that they don't want children? How do you address that situation when they don't believe contraception is needed?
Okay, so wait. So they're married, they don't want children, and they don't think they need contraception?
Right.
Am I understanding that right?
Right, Michelle.
Okay, thank you. I would want her to know that if she doesn't use any form of birth control, she has an 85% chance of becoming pregnant. That's the reality. And I would show her that chart, right, from Bedsider that Hannah showed you in the PowerPoint, that is great because of the graphics, that will show her this is what the outcome is likely to be. Therefore, can I talk with you about preconception care? Because you've got a very good likelihood you're going to become pregnant. So we'll need to be sure that you can be as healthy as possible when you conceive. I mean, it's just, we need to push back with information. It is absolutely her choice, right? She can know all of that and go away, and that's what she does. But we need to make sure that she knows exactly, that this is a very informed decision. And what we do, for example, if, would you like to become pregnant? No. We try to assess how strong of a feeling that is, because typically women who do not want to become pregnant are highly motivated to use contraception. So I'd have to say my other question is, so what else? So what else is going on? Is this a religious issue? Is this a cultural issue? But bottom line is, if she doesn't use any form of birth control, she is probably going to get pregnant.
I would say that those also, and I'm back in action. Excuse me for my cough. I would say that these situations do point out the nuances. A woman's reproductive health care option is, there's a lot of different options and education and information, but it does boil down to the patient, her goals and what she's comfortable with, and what are the different parts of her identity that are making her choose the different choices that she might be making, and anything we can do to remove different barriers to access, such as maybe giving out, ruling out some of the myths and misinformation about the birth control, which might have made someone not interested in taking them, or really accepting their answer that there are women who are okay either way, and what can our healthcare system do to change, to adapt to meet the need of that client who's not just a yes or no.
Right.
To Michelle's earlier point, do you know of any resources for counseling or guidance for women in religious environments to help them decide their, who seek religion to kind of help them decide their pregnancy plan?
Women in a religious environment who want counseling or information around reproductive life planning. Am I understanding the question right?
Right.
I would just say that it's interesting, actually, according to Guttmacher Institute, who is a think tank and researcher on a lot of things related to reproductive health, does indicate that a lot of women who identify in different types of religions actually do use birth control. So I think in some instances it is actually a common myth to think that religion might stop a woman from using birth control, because we do see a lot of them actually using it. And I would say that we have a few resources that would connect the idea of kind of, and it's not necessarily religious, but it could be combined, but kind of a cultural approach to talking about reproductive health. So taking into mind some different cultural barriers or contexts that might be different from the just average American experience, if there is one.
True. But at the same time, we do, I mean, as Hannah's saying, we know that 99 out of 100 women have used a form of birth control. What I know that both at the beginning of this question period and now this one, I'm trying to navigate the questions as it relates to a religious community or a religious institution. I would love to take, if this affects, more than one of you out there or several of you out there, it's like, let's have this as a very customized conversation, because there is a lot to this when we are talking either religious or cultural specificity.
Mm-hmm. Yeah.
And I just offer that as let's say as a supplement to this particular webinar.
Okay, I have a couple more questions for you guys. How have you used this tool in WIC groups?
In wage groups?
In WIC.
WIC.
Oh, WIC, sorry. Actually, I wasn't sure how to use it in a WIC group. WIC, it has been one of the questions that gets asked. And we've had a number of WIC programs, actually, that do it with great success, because they, in fact, identify about 25 to 30% of women who are saying that they don't want to become pregnant, and they are not doing anything to prevent that pregnancy. And those women really do want a referral, so that the WIC program then, makes that referral. The other thing that we both neglected to mention, and I just want to put out there, yes, this was created in Oregon. And one of the reasons the tool was created in Oregon is because we have because we had an opportunity to be able to focus on the problem of unintended pregnancy and develop this tool. But right now, we have providers in about 20 different states that are implementing one key question. So this is absolutely something that has been is being tested and has been tested outside of Oregon in a lot of different settings. We also have done focus groups specifically among Latino populations and Asian Pacific Island populations, and we are poised to do focus groups specifically around African American women to see, again, what the nuances are, what the acceptability is. But from the focus groups that we've done, we have gotten rich information about who should be asking them and when it should be asked in a visit, but they universally support the being asked the question. Were there other questions?
Yes, actually, I have one for you here. Do you have any advice for a healthcare worker who works with women in domestic violence situations who want an IUD but must wait 2 weeks before having unprotected sex?
Anna?
Well, I'm just trying to think back when I was at a family planning clinic. If there is a specific case that, I don't have all the information on that, but I would say in general, we would maybe offer a different type of birth control method during those 2 weeks. So perhaps using a pill patch during that time. But yeah, that does get tricky if they are in a position where and the reason why we wait 2 weeks is so that we can get a reliable pregnancy test. So, and also thinking about different contexts if that is necessary or if there's a way around that to make sure that she could. And that's also why the Paragard might be an option, because it is emergency contraception as well. Mm-hmm. So you don't necessarily have to have the 2 clear weeks, or so you could be able to get that.
The other thing I wanted just to add in terms of domestic violence, intimate partner violence, is that one of our pilots showed, it was a family planning clinic, county-wide clinic, and they also had a specialty program in identifying intimate partner violence. And their feedback was that when they asked women directly about intimate partner violence, that women did not necessarily respond and say, yes, it's an issue. But when they were asked, would you like to become pregnant, what surfaced in a surprising percentage of cases was, well, I would or I wouldn't, but, and that's where the identification of intimate partner violence actually surfaced as she was responding to, would you like to become pregnant? So it's definitely being done and has been done in the context of patients, women who are dealing with domestic violence.
Okay, and one last question. I'm sorry to the rest of you whose questions I wasn't able to get to, but we are on a time limit. So the last question, does your website have a screening tool that providers can use as a follow-up to One Key Question?
Our website doesn't, but our manual does. So
right.
Our One Key Question manual does have a couple pages on the follow-up information after you've asked, now what?
And the other thing, Teddy, just as so that your apology about other questions, if you have any way to get answers to the group that has been on this webinar, you could certainly send us those additional questions and we could answer them, and you could get our responses back out. I hate to leave questions lingering. The other option for people is, again, just to contact us directly, and we are always happy to have this conversation.
Great. Well, I would like to thank the both of you for joining us today. Would you like to give out any information how our attendees can contact you all if they have any more questions? I mean, they can contact me as well, but if they want to contact you all directly.
Sure. They can either contact Michelle with one L at prochoiceoregon.org or Hannah at prochoiceoregon.org.
I believe I put the screen back. Also the info, it's either our names at prochoiceoregon.org or info at onekeyquestion.org. We'll get that to us.
Awesome. Well,
no,
thank you both for
we would
joining.
love to be contacted. So please, any one of you that has lingering questions or wants to continue this conversation or access our implementation manual, please let us hear from you. Otherwise, just thank you so much for this opportunity to talk to you about our initiative.
Well, you heard it from Michelle. Michelle, there were tons of questions, so you just opened up Pandora's box. But this was a great webinar.
You know, honestly, that the questions give us that much more information about what we need to be addressing. So thank you all for taking the time to do that.
Great. Well, this concludes our webinar. I would like to thank all the PPs for joining us and everyone else as well. We will get back with you all next month for our next webinar. Thank you all for joining us. Thank you, Michelle and Hannah. And this concludes the webinar.
Thank you.
Wonderful. Thanks.